Good afternoon, folks. I hope this finds everyone well. This is part 2 in my lecture series on the human reproductive system. If you've not already watched part 1, I recommend that you go online and do that first so that you have the necessary background for this lesson. And if you have my class, I recommend that you get the handout off of Blackboard so that you have the necessary terminology and spelling of words and so forth in front of you. I also recommend that maybe you should have your textbook or your lab manual open so that you can be looking at relevant diagrams of the structures that I will be describing here as we follow along. So, in our last lesson, we looked at the general features of reproductive systems. We talked about gametes, about fertilization, a few other little details pursuant to that. We gave an overall layout of the human reproductive system, kind of like the male and female dichotomy there. And we went through the anatomy of the male reproductive system in detail, talking about spermatogenesis, the movement of sperm through the various parts, and the structure of the internal and external genitalia. So what I want to do with today here is to first finish out the male reproductive system and then to get started on taking a look at the more complex female reproductive system. So we finished talking about the various glands and structures attached to the male reproductive system, but one thing we need to discuss about it is the hormone that primarily drives it, and that of course is the hormone testosterone, T-E-S-T-O-S-T-E-R-O-N-E. There we go, testosterone. Got lost in the spelling bee in my head. All right, though, so testosterone is, of course, the major male sex hormone. It is what we refer to as an androgen, A-N-D-R-O-G-E-N, what is often called a masculinizing hormone. And there are a couple of different androgen hormones, testosterone being the most prominent one. Now, I should point out right away that testosterone is not exclusive to men, that the androgen and estrogen hormones are both found in both sexes, that women have masculinizing hormones, men have so-called feminizing hormones. This is not a thing that is exclusive to one sex or the other. A lot of the difference comes down to the amount of the hormone that is produced relative to the other one. In other words, men make more testosterone than women by a considerable margin, just as women make much more estrogen than men do. Now, testosterone, as you already know, is primarily secreted by the interstitial cells found within the testes. This is a hormone that is produced from the beginning of male development. That in utero, the effect of the testosterone hormone is to stimulate the development of the male reproductive system, that is, to make the modifications to the baseline female anatomy to change it into male anatomy. The default sex of all sexually reproducing mammals is female, and all mammals are sexually reproducing. And it is the presence of the Y chromosome and the genes present on it that code for the modification of baseline female anatomy into male anatomy, the sealing and outpocketing of the female labia to become the scrotal sac, the descent of the primitive gonads to become testes, the enlargement of the clitoris to become a penis, and a number of other factors like that. So testosterone before birth promotes development of the male reproductive structures and anatomy, as well as the descent of the testes. It should be pointed out that in infant girls, where there is a large amount of androgen hormone, often a result of adrenal tumors in mom, this can result in so-called masculinization of the female genitalia, in which there's an enlarged clitoris, a sealed vaginal orifice, and other features which cause the genitalia of the child to present as ambiguous. Now, during post-development, before development, it's mostly development of male reproductive anatomy and structures and descent of the testes. Later in development, during puberty, the levels of testosterone increase considerably. They're going to rise dramatically during puberty. They start from puberty, they slowly rise till about the age of 40, right around age 40. Testosterone levels slowly begin to decline. They, however, never go away completely after puberty. A man in his 80s might be producing 20% the testosterone that he did in his 20s, but he'll still be making it. A growing body of evidence also suggests that frequent sexual activity keeps the levels of testosterone higher, and therefore men who have more sex older in life will maintain higher testosterone levels, which seems to be an evolutionary adaptation that basically says, oh, I still have reproductive opportunities, ergo my body is going to keep on making things that will facilitate that. Now, at puberty, testosterone promotes the development of two sets of characteristics. We have the male primary sexual characteristics and the male secondary sexual characteristics. Primary sexual characteristics are going to be those features directly involved in the reproductive act. That is going to be the ability to produce sperm, spermatogenesis. That is going to be the ability to obtain erection. That is going to be the sex drive. That is going to be the enlargement of the male genitalia. These are the primary sexual characteristics. Secondary sexual characteristics are features of an organism that are not directly related to its reproductive activity, but nonetheless are stimulated by sex hormones and therefore serve as typifying features for members of a particular biological sex. Secondary sexual characteristics are the things we can look at in the animal kingdom and say that animal is a male or a female based on something other than its genitalia. Some species have a higher or lower degree of sexual dimorphism, D-I-M-O-R-P-H-I-S-M, dimorphism, two morphs, two shapes. Sexual dimorphism is the degree of difference in body size and in structural variation between the male and female of the species. In some species, there is virtually none. In penguins, for example, even zookeepers have to send out a genetic test to find out whether a given penguin is male or female, because the external anatomy really doesn't say that. In humans, like most primates, we have sexual dimorphism that is much more distinct. It is fairly easy to tell male from female on the basis of secondary sexual characteristics. In men, that would include the growth of body hair concomitant with puberty, particularly axillary hair, pubic hair, facial hair, and hair on the legs, back, and chest. Also, testosterone stimulates the coarsening and darkening of the skin. Male skin in our species is on average rougher and coarser than female skin and tends to be slightly darker pigmented. You're going to find also a coarsening and thickening of the hair. It may surprise you to learn that men and women have equal amounts of hair on their bodies. It's just that male hair is so-called terminal hair. It's thicker, it's darker and coarser, whereas more of the female body hair is vellus, which is a very thin, fine, colorless, downy sort of hair that gets to hardly any length at all. Other characteristics that we can expect to see coming from testosterone during puberty, we will see hypertrophy of the larynx and lengthening and thickening of the vocal folds, which has the effect of deepening the voice, and there's that rough transition period. Of course, all you guys listening remember that time in your teenage life when your voice would crack and break periodically because you were still trying to get used to the change in your vocal cords and their tension. You will also find that one of the effects of testosterone is to stimulate metabolism. On average, given the same diet and the same level of activity, a male of our species will have a higher metabolic rate than a female of our species. As a result, men will tend to burn through calories faster. This also means that men will have a higher growth rate. One of the things testosterone does is to increase skeletal muscle mass, to increase the development of thicker and larger bones, and to increase the levels of red blood cells. The male red blood cell count on average is about 20% higher than that of a female of equivalent activity level, which means that on average the male of our species tends to have a bit higher endurance in stress situations. You will also find that the male of our species on average tends to be a little bit larger bodied than the female of our species. The level of body size sexual dimorphism in humans is a lot less than many primates. For us, it is around 8%, meaning you can expect that on average, across the population, male humans are about 8% larger than female humans. That's again averaged out over the global population as a consequence of testosterone stimulating a greater amount of growth in the male body. This will lead to, on average, higher degrees of musculature in the male. On average, men have more muscle mass than women do. Smaller fat mass, the higher metabolism in men, means that on average the bodies of men retain a smaller percentage of fat than the bodies of women. Women on average store up to 14% more body fat than a man of equivalent diets, which accounts for the somewhat smoother features of females, the less angular features as compared to males in our species, whereby there are less fat stores subcutaneously. There are also differences in fat deposition. You will find that males tend to store excess fat primarily in the abdominal region, whereas females tend to store excess fat primarily in the pelvic and in the pectoral region, the hips and the breasts, which again counts for a shape difference that we expect to see in the male versus the female of our species. All these bioparameters, I should point out, are highly variable from one individual to another, that any given male may be smaller or larger than any given female, or have more or less muscle mass, or higher or lower metabolism. What I am talking about are the overall species trends, the average for Homo sapiens, looked at as a population as a whole, not that of individual organisms. Individual lifestyle factors and genetic factors can, of course, modify any given part of this. All right, so that is going to be our hormonal regulation of the male reproductive system. And to finish this out, let's talk a little bit about the male sexual act, the male parts of the reproductive process, which as compared to the female part is relatively brief and uninvolved, since once the male has delivered the sperm, his part in the actual mechanics are over. Now, the male reproductive act has three distinct phases. We have the so-called psychic phase. This is the phase that is initiated by mental stimuli. That is the awareness of a sexual partner, the awareness of the beginning of sex act, sexual imagery, that sort of thing. This effect causes a series of cascade reactions in which hormones are released that initiate erection, that action potentials from the brain stimulate more blood flow to the penis, that fills up sinusoids or cavities, sinusoids, which are found in the erectile columns. That causes the erectile tissues to expand, becoming more rigid or turgid as the fluid pressure inside of them increases. This has the secondary effect of increasing pressure on the veins leading out of the penis. By compressing those veins, it limits the amount of blood flow that is able to get out of the penis and therefore maintains the erection. Now, the psychic phase, as it's called, is initiated primarily by mental stimulus, but sensory stimuli, of course, can be a factor here as well. That can be tactile, visual, sensory stimuli. In general, you will find the male of our species is more responsive to visual and tactile than to scent and auditory signals. That's again a generalization. It is not the case across the boards. That in particular, the maintenance of erection is usually going to coincide with sensory tactile stimuli to the so-called erogenous zones of the body, erogenous, erogenous zones being any sexually sensitive areas for the male of the species. That is primarily the penis and glands, the scrotum, the anal and pubic region in general, and to a lesser degree the nipples and some sensitive points in the facial tissue, like the ears and the lips. Now, stimuli to any of these areas, particularly a rhythmic stimulus to the shaft of the erect penis, will cause sensory sensations that are stimulated not only in the brain but also in the spinal cord. It is worth noting that an awful lot of this is not regulated by the brain, that the spinal cord handles a great many of the nerve fibers that are related to the sex act and actually sends out a lot of the signals related outside the conscious control of the brain. Mostly the signals involving the maintenance of erection and the stimulation of the production of semen, as well as the actual act of orgasm. That brings us to the second stage of the male sex act, which is called emission, M-I-S-S-I-O-N, the emission stage. During this stage, what's going to happen is that sperm and seminal fluids are going to accumulate in the urethra, that we're going to have a gradual buildup of fluid pressure as the various components of semen are going to come together and begin to build up in the male urethra. This is going to be triggered by peristaltic contractions. That sensory stimuli of the male sense organs will cause peristalsis throughout the male reproductive tract, which will have the effect of pushing prostatic fluid, seminal vesicle secretions, bulbourethral secretions, and sperm all into the urethra. In turn, the stretch of the urethra is going to send an action potential along a nerve called the pudendal nerve, P-U-D-E-N-D-A-L, from the male genitalia to the spinal cord. The spinal cord, upon this signal, will cause a constriction of the internal urethral sphincter. Remember that sphincter that closes off the opening to the urinary bladder from the urethra? It's going to constrict at this time. This prevents the release of urine into the urethra at the same time as the release of semen, since the acidic secretions in urine would pretty much kill the sperm. And further, this is going to send a motor signal to the skeletal muscles surrounding the bulb of the penis. Tension will rise in those muscles, and although there is a degree to which they are under voluntary control, it is technically a skeletal muscle, the more tension rises in that muscle and the more fluid pressure accumulates in the male genitalia, eventually, as with the fact that eventually, no matter how much you hold it back, you're going to have to pee, eventually, no matter how much one endeavors to hold it back, the seminal fluids will have to be released. At that time, there will be ejaculation, E-G-A-C-U-L-A-T-I-O-N. Ejaculation is the forceful ejection of the contents of the urethra. This is a series of hard rhythmic spasms of the skeletal muscles surrounding the urethra, projecting the semen from the tip of the penis in waves, emerging from the external urethral sphincter, and then presumably projecting into the female reproductive tract. Ejaculation, I should point out, is not exactly the same thing as orgasm. That we often use those words simultaneously, and the reason for that is because usually they do coincide. Normally, orgasm happens at the same time as ejaculation. Ejaculation is the physical projection of semen from the penis, but orgasm is a series of other events, not only the spasms within the penis, but also a strong release of a wave of dopamine in the central nervous system, causing an intense wave of pleasure that tends to shut down most other cognitive processes while it is going on. This is usually accompanied by an increase in the force of pelvic thrusting associated with copulation, and in particular with a forceful thrust accompanying the moment of ejaculation, which from an evolutionary level has the effect of projecting the semen more deeply into the female reproductive tract, thereby increasing the odds of fertilization. Final stage of this process is going to be resolution, R-E-S-O-L-U-T-I-O-N. During the resolution phase, the penis becomes flaccid, F-L-A-C-C-I-D, meaning that it loses erection and tension, that blood flow reduces to the penis, the compression on the veins reduces, allowing drainage of accumulated blood, and the penis begins to soften and shorten. That remaining semen and pre-ejaculatory fluids are going to leak out at this time. Then there's going to be a strong wave of dopamine and oxytocin that passes through the body at this time, O-X-Y-T-O-C-I-N. Oxytocin is sometimes referred to by endocrinologists as the cuddle hormone. Oxytocin is a pituitary gland hormone that causes feelings of relaxation, pleasure, and contentment, and particularly promotes a sense of emotional bonding with other human beings, which means that you have a sense typically of a strong emotional bond with the individual into whom you've possibly just introduced your reproductive cells. which you can see why at an evolutionary level that would be a potentially useful thing for fostering conditions in which your offspring will do well. I should point out that there are two major times when the human body produces large amounts of oxytocin. One of those is immediately following orgasm during the resolution phase. The other one is immediately following childbirth, that immediately after parturition, when a woman has finished giving birth to the child and the muscular contractions within the reproductive tract of the female slow down, that's accompanied by a significant wave of oxytocin, causing a feeling of contentment and emotional bonding right at the moment that mom sees her child for the first time. Ergo, promoting a sense of emotional bonding with the child, which again, from an evolutionary level, means a greater likelihood of that child surviving. All right. So that is, I mentioned one thing in there I kind of glossed over, that one of the things that happens during the, starting during the psychic phase, but continuing into the emission phase, is that prior to ejaculation, the penis will release a so-called pre-ejaculatory fluid. The pre-ejaculatory fluid is a lubricating fluid that leaks from the external urethral sphincter. Pre-ejaculatory fluid has the effect of lubricating the penis and therefore facilitating the rhythmic massage action of copulation that stimulates the buildup of tension and the eventual release of semen. So both sexes produce lubricating fluids prior to the sex act. The male less than the female, but the male also has a lesser surface to lubricate. The female has an entire reproductive tract to lubricate, but the male has fluids involved with that as well. All right. So that pretty much brings us to the end of the male reproductive system. But now let's start talking about the somewhat more complex female reproductive system. As with the male, we have both internal and external female genitalia. The internal female genitalia are considerably more elaborate than those of the male. Internal female genitalia include the female gonads, the ovaries, O-V-A-R-I-E-S, or ovary, singular, O-V-A-R-Y. The uterine tubes, U-T-E-R-I-N-E, also called the fallopian tubes, F-A-L-L-O-P-I-A-N, capitalized fallopian. We have the uterus, U-T-E-R-U-S, and we have the vagina, V-A-G-I-N-A. I should point out that all these structures are suspended from the peritoneum. They are all peritoneal organs, attached by a sheet of tissue called the broad ligaments. Now, external female genitalia would include the labia, the clitoris, the clitoral hood, the vestibule, V-E-S-T-I-B-U-L-E, and a few glandular structures associated with them. Now, little terminology here. The word vulva. And there's another word that you will sometimes see in older anatomy textbooks in lieu of vulva, but let's clear up another bit of confusion first. The word vulva versus vagina. It is a common colloquialism in our culture to use those words synonymously. They are not the same thing. A lot of people get into the habit of referring to the entirety of the female genitalia as the vagina. That is not at all the case. The vagina is a specific internal structure of the female genitalia. It is the membranous tube connecting the vaginal orifice, the opening to the outside of the body, O-R-I-F-I-C-E, orifice, to the uterus. So the vagina is that muscular membranous tube inside of the body. It is not the external structures. So calling the external parts of the female genitalia the vagina is erroneous. The vagina begins on the inside. The external structures, the vaginal orifice, the labia, the clitoris, all of that is collectively referred to as the vulva, V-U-L-V-A. So that's the external female genitalia. A term you will sometimes see in older anatomy textbooks, and I want you to be aware of it in case you see it, but I don't want you to use it, is the term pudendum, P-U-D-E-N-D-U-M, pudendum. And you might have noticed that's similar to a term that I used before, the pudendal nerve, going to the genitalia. The word pudendum is an old word that literally translates as the place of shame. And this is derived from a rather misogynistic early view of the female body, which suggested that female sexuality was inherently shameful and dirty, that female sexual pleasure was inherently a shameful thing. Needless to say, this is a very outmoded attitude, a highly misogynistic attitude, and a highly sexist attitude, and one that we do not need. So sometimes in here I give you alternate names for different body parts. Technically, the pudendum is an alternate name for the vulva, but I don't want you all using very misogynistic terminology for the human body here in the 21st century, so let's just dismiss that term from the lexicon altogether, call it the vulva. Now, you are going to have to deal with pudendal nerve, which is found in both male and female, and a couple of other pudendal, structural names that have not yet gotten an alternate name for them, but let's just not use the term pudendum for the female genitalia. All right, so now let's kind of work from the outside in, from the female genitalia. From the male reproductive tract, we worked from the inside out, starting at the testes, working our way out to the penis. Let's work opposite way for the female reproductive tract, start from the outside and work our way deeper in. Now, externally, first thing we're going to encounter is going to be the vulva, the collective outside structures of the reproductive system in the female. Central to this is the vestibule, V-E-S-T-I-B-U-L-E. The vestibule is the common space opened into by both the female urethra and the vagina. On either side of the vestibule, you'll find longitudinal folds of skin called the labia minora, L-A-B-I-A, minora, M-I-N-O-R-A, the labia minora, or lesser lips of the vestibule. In the center of the vestibule, between the labia minora, you will find the vaginal orifice. The vaginal orifice is the entrance to the vagina. Immediately superior to that, you will find the external urethral orifice, through which the urine is going to pass out. Between the vaginal orifice and the labia minora, you will find ducts leading to the greater vestibular glands, and also the paraurethral glands, P-A-R-A-U-R-E-T-H-R-A-L. So the greater vestibular glands and the paraurethral glands are both going to be secreting lubricating fluids onto the external tissue of the vulva. Now, if you look at the anterior margin of the vulva, kind of continue up above the vestibule, above the external urethral orifice, you will find a small fleshy structure called the clitoris, C-L-I-T-O-R-I-S. The clitoris is evolutionarily homologous, or I should say analogous, to the male penis. From a developmental standpoint, they are the same structure. It has often been stated that the clitoris resembles a small penis. I would say it is way more accurate to say that a penis is a large clitoris, inasmuch as the clitoris is the basic structure which is then modified and enlarged during male development. Now, unlike the male penis, the female urethra does not pass through the clitoris. It is located superior to the clitoris. The clitoris is superior to the urethra. So that's a totally separate opening that's not involved with the clitoris at all. The clitoris itself is a small erectile structure. The external portion of it is averaging 2 centimeters long. It is protected, like the glands of the male penis, by a prepuce, or foreskin, often called the clitoral hood, H-O-O-D. Now, on either side of the clitoris, you will find the lesser vestibular glands, which serve to secrete lubricating fluids. As compared to the male penis, remember male penis has 3 erectile columns. The male penis has the 1 corpus spongiosum and the 2 corpora cavernosa. The clitoris does not have the corpus spongiosum. It only has the corpora cavernosa, so left and right portions of the clitoris. Now, those erectile tissues will become engorged with blood during the course of sexual arousal, which will mean that the clitoris will become enlarged. It will typically thicken but not significantly lengthen. A slight lengthening, but mostly an increase in thickness. The clitoris is highly innervated. And with sexual stimulus, it provides very powerful sensation. It's actually the single most innervated structure in the female body. So lots of nerve endings, highly sensitive to touch. And it is the single feature of female anatomy that provides the highest degree of sexual stimulus, far more so than the vaginal canal itself in most females. Now, the clitoris as we see it, however, is not the entire structure. We have this idea the clitoris is this little tiny bump of tissue, but in point of fact, most of the tissue of the clitoris is internal. That if you go deep below the surface of the vulva, you will find that the clitoris continues with masses of erectile tissue that curve around either side of the vaginal orifice. So that on either, lateral to the vagina on either side, you will find the bulbs of the vestibule, which are technically part of the clitoris. They too become enlarged during sexual arousal. They gain a certain amount of erection as well, causing the tissue around the vulva to visibly swell when sexually aroused. The entirety of the clitoris is anchored to the pelvic bones by the cruca of the clitoris, C-R-U-C-A. So internally, the clitoris is actually a fairly large structure. It is bigger than the penis in terms of the overall amount of erectile tissue. Present is just most of it is internal. Now, immediately lateral to the labia minora. So if we've got the vaginal orifice in the middle, labia minora on the outside, you can't see the clitoris curving around internally, but immediately lateral to that, you will find the labia majora. The labia majora are larger and fleshier folds of tissue. They are highly innervated, much like the clitoris, not quite as much so, but still very highly sensitive. They too secrete lubricating fluids, or rather they receive lubricating fluids secreted by the other glands previously mentioned during sexual arousal. They too will also become engorged with blood and visibly swollen during arousal. Now, the labia majora normally will close over the vaginal orifice. The gap between them is technically called the pudendal cleft, C-L-E-F-T. A cleft is a gap or a groove. You want to call it the vulvar cleft, or the vestibular cleft. I kind of prefer that terminology, but pudendal cleft is still what you see in most textbooks. Now, the labia majora curve up over the tissue of the vulva, and they unite superior to the vulva at the location of the pubic symphysis, the point where the pelvic bones join just above the external genitalia. That will form a mound of tissue, a sort of raised mound of tissue called the mons pubis, or pubic mound, M-O-N-S. Immediately superior to the female vulva, it's also a highly innervated structure. Now, if you continue in the other direction, go inferior to the vulva, continue below the vulvar cleft, you will find a little patch of tissue called the perineum, P-E-R-I-N-E-U-M. Both men and women have a perineum. The perineum is the small patch of tissue at the base of the groin that lies between the external genitalia and the anus. Now, in the female of our species, this is an important consideration because the male of our species, the male genitalia don't have to worry about pushing anything big through them. Now, obviously, female genitalia, a big portion of the vaginal canal's job is not just receipt of sperm, but also release of infants. And during the process of parturition or childbirth, it is not at all uncommon for the perineum to tear. It's very common that as the baby pushes through the vaginal orifice, that as it stretches and stretches the tissue, that the perineum will become torn. And that's a frequent post-surgical complication that we have, post-childbirth complication. In some cases, requires surgical stitching immediately following. A practice that is still occasionally done in medicine, but used to be a lot more common, was an operation or a simple procedure called an episiotomy, E-P-I S-I-O-T-O-M-Y. An episiotomy is making a vertical cut from the base of the vaginal orifice down into the perineum. in order to widen the opening that the child passes through. The idea here is to allow the infant to pass through without tearing of the perineum. And while that sounds good on paper, recent research has suggested that in many cases a episiotomy is not as good an option as natural tearing, that natural tearing seems to heal more effectively than a deliberate cut, and that the very neat, even cut of an episiotomy has the unfortunate side effect of creating a sort of seam at the healed opening, whereby in subsequent childbirth, if that woman should happen to give birth to another child, tearing along the site of the previous episiotomy is very, very common. Ergo, it's increasingly being thought by physicians that to do less damage to the tissue surrounding the vulva and the muscles of the pelvic floor wall, it is actually better for natural tearing to happen if it's going to happen rather than doing an episiotomy. But the procedure is still done from time to time, particularly if mom is particularly small-bodied and the infant is particularly large-bodied, and its natural childbirth is being attempted. So that is our external tissue. That's our vulva. All of this that I've been talking about, the external clitoris, the labia majora and minora, the vestibule, the vaginal orifice, the mons pubis, all of this is collectively the vulva, the female external genitalia. Now, let's continue inward. Let's pass through the vaginal orifice, where you will immediately pass into the vagina. The vagina is the female organ of copulation. That is the organ that is the analogous organ to the male penis. The male penis, remember, is the intromittent organ. It is the organ that is being placed into the female body to deliver semen, whereas the vagina is the passageway into which it is entering. The vagina receives the penis during intercourse. It also allows for menstrual flow. It's the orifice through which the products being shed during menstruation are going to leave the body. And of course, it is also the passageway for childbirth. It's the passageway through which the infant passes during parturition. Now, the vagina is a muscular walled tube. Average vagina in our species is approximately 10 centimeters long from uterus to vaginal orifice. The superior portion of the vagina, which is called the fornix, F-O-R-N-I-X, is directly attached to the cervix, C-E-R-V-I-X, which is at the posterior end of the vaginal orifice. The cervix is going to be the opening leading into the uterus. More about that in a few minutes. Now, you will find that the walls of the vagina have an outer layer of smooth muscle containing a lot of elastic tissue for reasons that should be fairly obvious. The vagina has to be able to stretch considerably to allow the passage of an infant. You also are going to have a certain amount of skeletal muscle surrounding the vagina that is subject to deliberate contraction in the course of labor. But in any case, however, some of you might be aware of Kegels, K-E-G-E-L. That is, their muscles to strengthen the skeletal exercise to strengthen the skeletal muscles surrounding the vagina, which can then help with the childbirthing process later. Now, the inner lining of the vagina is a mucous membrane. It is a stratified squamous epithelium, but it is a moist stratified squamous epithelium, non-keratinized, continually well lubricated by the production of mucous fluids. It's highly elastic. That lubrication and elasticity allows it to stretch to accommodate both the penis going in and the infant going out. Now, having that mucous lining there is also important not only for preventing abrasion whenever something is passing through either way, but also for protecting against external pathogens, because the vaginal orifice is, like the mouth, a possible opening into the body through which bacteria can potentially enter. So having lots of mucus present in there traps pathogens that otherwise might get in, which can then be discharged through that orifice. Now, the vaginal orifice in young women, if you go a little bit into the vaginal orifice, you'll find that just inside there's commonly a membrane found in young women called a hymen, H-Y-M-E-N. The hymen at one time was believed to be a solid barrier that just broke the first time a woman had sex. Shakespeare poetically called it the maidenhead. And that's still a persistent belief. And in point of fact, a lot of women do have a hymen that is at least partially intact at first intercourse. And will very often bleed. There's a reason a lot of women will bleed the first time that they have penetrative sexual intercourse, simply because the hymen has been broken. I should point out the hymen is not a solid barrier. It does have numerous openings in it. It has to allow menstrual flow. And that the hymen is not even present in all women. And it is very frequently, and actually about 2/3 of women, ruptured earlier in life prior to sexual activity. It can be easily broken by forceful impact, by jostling of the body. If you are engaged in rough sports, particularly riding sports like bicycle riding or horse riding or whatever, it is very common for the hymen to have ruptured prior to childbirth. So the hymen traditionally, in a lot of societies that placed a high value on female virginity, has been considered an indicator of virginity, like an intact hymen, proof that a woman was a virgin in cultures where that was considered desirable, that a woman be a virgin at marriage or what have you. So much so that in some societies there was there was a very much misogynistic practice prior to a woman giving birth of having usually an older female relative examine her to see if she had an intact hymen, and lack of an intact hymen could be an indicator that she was not fit for marriage because presumably she'd already had sex with someone. Needless to say, this is a very outmoded and misogynistic way of thinking. At one time, there was a common custom in a lot of societies. It's a Middle Eastern custom in Abrahamic societies, Jewish, Islamic society in the Middle East, that at one time there was a custom where following the wedding night, that a bloody sheet would be displayed to the family as proof that the girl had been a virgin prior to her marriage. Obviously, again, there's all kinds of misogynistic cultural baggage wrapped up in all of this. And from a biological standpoint, I am here to tell you that the hymen doesn't really mean anything. It's a membrane. It will not be intact in most women before sex anyway. It's not going to change your physiology one way or another, and really getting it out of the way just means easier menstrual flow one way or another. So it's not really a thing you need to be concerned about, and it is certainly not a reliable indicator of virginity if for some reason you've decided that is an important thing to be concerned about. All right, so continuing through the vagina, at the superior end of the vagina, you will encounter the cervix, cervix. The cervix is going to be the muscular sphincter, which controls the opening to the uterus. Now, the uterus, of course, is the primary organ of gestation, gestation. Gestation, of course, being the growth and development of the child prior to birth. Now, the uterus is kind of a pear-shaped organ. Think of like an upside-down pear with the wide end superior and the narrow end inferior, located within the pelvic cavity. At rest, whenever it is not full of a baby, the uterus is a pretty small structure. It's about 7.5 centimeters long and only about 5 centimeters wide. Obviously, it is going to be highly elastic and able to stretch to a much, much larger extent in order to accommodate a growing infant. Now, you will find that the uterus is joined to the ovaries laterally by the uterine tubes, that if you look at the bulging parts of the uterus at the top, the uterine tubes curve up and over, down towards the ovaries from there. If you're looking at the uterus, it bulges up a little bit above the location of the uterine tubes. You're not at the very top of the uterus bulges slightly above them. That portion of the uterus above the uterine tubes is called the fundus, F-U-N-D-U-S. The main space of the uterus is called the body of the uterus, also the uterine cavity, the space within it. Uh, it narrows at its inferior end to the cervical canal, cervical, which is going to then open into the vagina at the cervix. Entire uterus is held in place by several ligaments. We have the broad ligament that I already mentioned, which suspends all of the female internal genitalia from the peritoneum. We have the round ligaments. The round ligament binds the uterus anteriorly to the labia majora. And then we have the uterosacral ligament, Terosacral, which, as you can probably guess, binds the uterus to the sacrum. All of these ligaments suspend the uterus in place, and it is also supported inferiorly by the sheets of muscle at the base of the pelvic floor. Now, if you look at the walls of the uterus, the outermost wall of the uterus, the outermost layer, is the perimetrium, Perimetrium, also called the serous layer because it secretes serous lubricating fluids. The perimetrium is actually part of the visceral peritoneum. Remember back when we talked about the digestive tract, that we talked about the visceral peritoneum that directly covers the outside of abdominal pelvic organs, and we talked about the parietal peritoneum that forms the lining of the inner body cavity. Well, the perimetrium is technically part of the visceral peritoneum. Now go deep to that. We will find the middle layer of the uterus, which is the myometrium, myometrium, myo meaning having to do with muscle. The myometrium is the muscular layer, and sometimes just called the muscular layer. And it is the thickest smooth muscle in the human body. It needs to be because the contractions associated with labor are just about the most forceful muscular push that the body generates. And then finally, we have the inner lining of the metrium, of the uterus, called the endometrium. Endometrium. This is going to be a mucous membrane. It is a simple columnar epithelium. It secretes lots of mucous fluids to protect the walls of the uterus against pathogens. It is ciliated to push that mucus out, and also, incidentally, to carry the zygotes whenever it enters the uterus. Embedded in that inner wall, you will find endometrial glands. The endometrial glands secrete compounds related to both infant development and to childbirth. You will also find that in the cervical canal, we have cervical mucus glands, and it's mucus, M-U-C-O-U-S, not M-U-C-U-S. Remember, M-U-C-U-S is the fluid, M-U-C-O-U-S is the adjective describing a kind of membrane that secretes them. That provides a lot of cervical mucus, which again is primarily going to be a barrier to foreign substances entering the uterus. You will find that when a woman is ovulating, the cervical mucus becomes thinner and less viscous, and this has the effect of making the passage of the sperm considerably easier. Now, obviously, the uterus has a lot of elastic tissue in its walls. It has to, because again, it has to expand considerably. It has to be able to accommodate the entirety of a growing infant up until the moment of parturition, and in some cases, more than one growing infant. Now, the uterus may be the organ of gestation, but it is not the organ of fertilization. The act of fertilization does not actually take place in the human uterus. Rather, it takes place in the uterine tubes. The uterine tubes go by a couple of other names. They are also called the oviducts, O-V-I-D-U-C-T-S, which literally means egg ducts or egg tubes. They are also more commonly known as the fallopian tubes, F-A-L-L-O-P-I-A-N. Capitalize the F in fallopian if you call them that, and that is a case in which you're going to hear that term a lot in gynecology and in obstetrics and other medical professions. The term fallopian tubes is probably more commonly used than uterine tubes. Again, my preference is you use the non-eponymous names, call them names that are more technical, but you're going to hear fallopian tubes quite commonly. fun story here, since we haven't had one of those for a little while. The fallopian tubes are named for the man who first described them. He was an Italian physician and instructor at the University of Padua during the Renaissance by the name of Gabriel Fallopio, Fallopeo. He often went by the Latin name Fallopius because in those days, Pius, because in those days it was very common to Latinize one's name because all scientific and medical writings done in medieval Europe were done in Latin. So Gabriel Fallopio was better known as Fallopius, hence the term fallopian tubes. He was a student of a guy you might have heard me mention here previously. He was the student of Andreas Vesalius. And if you don't remember that name, Vasalius, Andreas Vesalius, is often called the father of modern anatomy. He's the guy who, way back in the early Renaissance, in the early 1500s, began advocating for anatomical dissection as the only proper way to learn how to do medicine at a time when that was not common. And in particular, he advocated for medical students doing the dissections for themselves, getting their hands on an actual human body, poking around inside of it in order to learn how it worked. Which sounds like a no-brainer to us today, especially those of you taking a whole class on that right now. But Vesalius's anatomy classes revolutionized medicine. He introduced all kinds of new ideas to the medical curriculum, including the hands-on dissection. He ended up publishing the first illustrated anatomy textbook called The Fabric of the Human Body, De Humani Corporis Fabrica, or the Fabrica, as we often call it for short in the history of medicine. The Fabrica was the first real serious guide to human anatomy and medicine written from an observational perspective, and it ended up challenging a lot of the false ideas held by ancient physicians like the ancient Roman physician Galen and the ancient Greek physician Hippocrates, neither of whom had done all that much human dissection and therefore did not really know their way around the human body as well as they probably should have. Vesalius's work was the beginning of modern anatomy, and from that point onward, his model of education remained the default way of doing the anatomical sciences. His anatomy classes actually became so popular in the Renaissance at the University of Padua, Padua in Italy, that he eventually, that the city of Padua began timing the execution of criminals around his lecture schedule to make sure that there were fresh bodies available for his students to work on. Now, for all that he was a rather remarkable anatomist and one of the most important figures in the history of modern medicine, as well as modern biology as a whole, Vesalius ended up leaving his post at the University of Padua only a couple of years after he published his landmark Fabrica. And that was largely because he was, frankly, pissed off about the fact that even though he was talking about clear, obvious, observational, look right there, you can see it evidence that Galen, the ancient Roman physician, who was the basis of medical curriculum in his time, was wrong. And he was sick of having to defend his ideas against, conservative backlash that basically said, well, of course Galen is right. Galen's the guy we've always listened to. The ancients had all the right ideas. He's the founder of the field. How dare you challenge him? And Vesalius said, I challenge him because that's how science works, and here's evidence. Look at it. You can stare right into this corpse right here, right now, and see that Galen had it wrong. And for reasons that should be fairly clear, he got distressed at having to continually defend his evidence-based medicine against a lot of people who just stuck their heads in the sand and wanted to keep doing things the way they had always done them, regardless of what empirical evidence had to say. Science denialism is not new. And eventually Vesalius threw up his hands in disgust, quit his post at the University of Padua, and went into private medical practice. Although admittedly, he got a pretty good gig. He was the personal physician to the Holy Roman Emperor, so not like he worked out badly. But whenever he left Padua, he installed one of his students as his successor as the chair of anatomy and surgery there, Gabriel Fallopio. And Fallopio made among the first detailed examinations in his dissections of the female reproductive system. Leonardo da Vinci had actually studied it in some detail prior to him, but at that time da Vinci's papers were not widely circulated, and he was not nearly as well known in his own time as it is today, and as such hardly anybody knew about that. But Fallopio did a very detailed study of the anatomy of the female reproductive tract and discovered the tubes that are named for him. I think my favorite little fact about Falloppio is that he also introduced the first clinical trial of a prophylactic condom, that he was an advocate for study of sexual dysfunction. He attempted to study drug remedies for erectile dysfunction, didn't really come up with much. He endeavored to learn about sexual disorders and better ways to treat sexually transmitted diseases. And among those, he said, well, let's try a barrier-based approach. And he introduced the first condom as a prophylactic tool. It was not intended as a birth control mechanism. It was intended as a defense against sexually transmitted infections. The condom that Falloppio was advocating in those days was probably not a tool that you would want to employ today. It was made out of a length of sheep's skin. It was meant to be washed out and reused, and it tied on at the base of a little pink ribbon that was supposed to appeal to the lady. So that's my Gabriel Falloppio trivia for today, but it is him for whom the fallopian tubes are named. Anyhow, though, so getting back to the actual anatomy here, the fallopian or uterine tubes, or oviducts, are a pair of narrow tubes about 10 centimeters long. Each of them extends from the lateral side of the uterus, left and right, curves upward along the length of the broad ligaments, and then curves downward to each ovary, where they end just before each ovary. Note that I said they end just before the ovary. The uterine tubes are not attached to the ovaries. There is a small gap between them. The opening of the tube actually opens directly into the abdominopelvic cavity. There is no barrier at the end of the uterine tube. There's just a gap between it and the ovary. That, incidentally, allows us to do some interesting some surgical procedures that don't require incision on the female body. For example, a woman can have her appendix removed through her vagina, because what we can do is we can run the surgical scope up through the vagina, through the uterus, through the uterine tubes, out of the uterine tube into the abdominal cavity, direct it to the appendix, clip it out, and then pull it back out the way it came through. So that's a way we can actually remove an appendix from a woman's body without needing to make a surgical cut. And you can also scope around inside the female abdomen in the same way for non-invasive probing. Well, okay, it's pretty invasive, but non-surgical probing. Now, in any case, though, you might be thinking, okay, if the ovary is not attached, how do we get the egg there? And the reason for that is that if you look at the end of the uterine tube, it enlarges at the end, it slowly widens. It's about 10 centimeters long, but 7.5 to 8 centimeters of it is a slowly widening passage called the ampulla, A-M-P-U-L-L-A. If you've not figured that out by now in the course of several lectures, an ampulla, anatomically speaking, is an enlarged space to hold a fluid or to hold a material or whatever. Basically, it's the enlarged end of a tube. But at the very end of the uterine tube is a funnel-shaped opening called the infundibulum. I-N-F-U-N-D-I-B-U-L-U-M, the infundibulum. The infundibulum is the kind of trumpet-shaped opening at the end of the uterine tube, located just adjacent to the ovary. Around the mouth of the ampulla, you will find long, thin, finger-like processes that extend from its edge called the fimbriae, F-I-M-B-R-I-A-E. The fimbriae serve to catch the egg when it comes out of the ovary and sweep it down into the uterine tube. So during ovulation, when the ovary releases an egg, the fimbriae are there to grab it and pull it down in. If they do not successfully catch the egg will just drop down into the abdominal cavity and will have no chance of being fertilized down there, and you just can't get pregnant that month. If you look at the lining of the uterine tubes, they have an outer serosa, or serous layer, just like the uterus, which is also a part of the visceral peritoneum. They have a middle smooth muscle layer, the muscular layer, and they have an inner mucosa. Like the uterus, it is lined in a simple columnar epithelium, and it has lots and lots of cilia. And the cilia are quite important because once the egg enters the uterine tube, the cilia will catch it and move it down the length of the tube. A combination of peristaltic muscular contractions and movements of those cilia will carry the oocyte, the egg, down into the uterine tube where it will await the sperm for fertilization. Fertilization takes place in the ampulla of the uterine tubes. Once the egg is fertilized, the zygote, Z-Y-G-O-T-E, the fertilized egg that results, will then be carried by those cilia down and out of the uterine tube and into the uterus. All right, now this brings us at last to the female gonads, the ovaries. We started the male reproductive tract with its gonads, the testes as the source of spermatozoa. Now we worked our way inward with the female reproductive tract, finally getting to the ovaries, which are the female gonads, the source of oocytes or eggs. Now the ovaries, like the testes, are paired organs, slightly smaller than the male testes. On average, each ovary, it's an almond-shaped structure, about 2.5 to 3 centimeters long, only 1 to 1.5 centimeters wide in the average woman. The ovaries are supported by 3 ligaments. There is a suspensory ligament, S-U-S-P-E-N-S-O-R-Y. The suspensory ligament binds the ovary to the lateral body wall. We have the ovarian ligament, O-V-A-R-I-A-N, which attaches the ovary to the superior margin of the uterus. And then we have a portion of the broad ligaments, which, as you know, binds the ovary to the peritoneum, like all the other peritoneal internal female reproductive organs. By the way, that branch of the broad ligament that goes to the ovary also carries nerves and blood vessels that run to it to supply it with nutrients and sensation. Now, if you look at the ovaries themselves, they are covered externally by a serous layer consisting of the visceral peritoneum. Beneath that, we're going to find a dense layer of dense irregular connective tissue, a capsule called the tunica albuginea, Tunica-albuginea. That term should sound familiar to you because the testes also are protected by a tunica albuginea. Remember, these are analogous structures. They have the same basic developmental pathway, and anatomically they're very, very similar. The tunica albuginea is denser. The outer layer of the ovary is the cortex. The inner layer is the medulla. This is also terminology you've heard before, that a lot of structures in the body have an outer layer that is the dense cortex and a looser inner layer that is the medulla. Throughout the ovary, you're going to find numerous vesicles known as follicles, F-O-L-L-I-C-L-E-S. Those are distributed throughout the cortex of the ovary. The follicles are each going to be the site where an oocyte will develop. Each follicle is a site of oocyte development. So let's talk for a moment then about the generation of female gametes. Let's talk about oogenesis. O-O-G-E-N-E-S-I-S. Oogenesis. Remember, it's not uncommon with anything oocyte, oogenesis, any of these things that begin with the 2 O's, to put an umlaut, 2 little dots over the second O. That's basically like a pronunciation placeholder that shows you pronounce each O separately. So it's not oocyte or oogenesis, it is OO. Now, males do not begin forming sperm until late in life. Remember, males are the fast sex. Males produce large numbers of gametes very quickly. Male spermatogenesis does not begin at all until puberty, and then it continues throughout the adult male's life. Oogenesis is very different. Pardon me, folks. All right, so oogenesis begins during fetal development. A woman begins to form eggs in her ovaries before she is even born. By the time a female human fetus is 4 months into its development, its ovaries contain approximately 5 million oogonia, oogonia. You might recall that spermatogonia are the precursor cells for spermatogenesis. Oogonia are going to be the precursor cells for oogenesis. And each oogonium has 92 chromosomes. It is a tetraploid cell with 4 copies of each chromosome rather than the usual 2. Now, here's the thing. We at one time had a belief, and had I been teaching this class to you a decade ago, I would have told you that oogenesis was finished entirely before birth. Because for a long time, the belief in anatomy was that a woman was born with all the eggs she would ever have. In point of fact, we have realized that is not true. It slows down considerably after birth, but oogenesis does not completely end until menopause. So the female body does not just have a stockpile of eggs that it gradually uses up. For a long time, we kind of thought the way it was okay, a woman is born with X number of eggs, she uses them up throughout life as she ovulates, and when she runs out of eggs, she goes into menopause. We have since learned that is not the way things are. For starters, you're never going to run out of eggs. And secondly, oogenesis of new eggs does continue for the remainder of your fertile life. Now, that 5 million oogonia develop by month 4 or so of pregnancy. By the time the female infant is born, only about 2 million of those oogonia are left. They will give rise to primary oocytes. Actually, by the time the woman is born, there are about 2 million primary oocytes. oocytes. Primary oocytes have been through meiosis 1. They have 46 chromosomes each. Many of those will die before puberty. By the time the female reaches puberty, on average, she will have 300,000 to 400,000 remaining primary oocytes. During the course of a fertile lifetime, the average human female will produce approximately 400 fertile eggs. About 400 of those 300,000 to 400,000 primary oocytes will give rise to a secondary oocyte, which we know better as an egg. Now, each primary oocyte is going to be surrounded by a layer of cells that we call granulosa cells, Granulosa, forming what is called the primordial follicle, Primordial, the primordial follicle, the initial outside coating. That, in turn, is surrounded by a clear connective tissue layer called the zona pellucida. Zona, Z-O-N-A, pellucida, P-E-L-L-U-C-I-D-A. Now, what's going to happen is that throughout maturity, as that follicle begins to mature, that primordial follicle is going to become a primary follicle when the oocyte begins to enlarge. The primary oocyte will get bigger. The primordial follicle will become a primary follicle. That is when the zona pellucida actually forms. And once it has a zona pellucida, it is said to be a secondary follicle. So primordial follicle is just granulosa cells. And then it's going to become a primary follicle when the oocyte begins to enlarge in preparation for meiosis 2. And then when it's surrounded by a zona pellucida, it becomes a secondary follicle, and vesicles begin to form around the entirety of the follicle, embedded within the granulosa cells. The entire thing will be surrounded by an external capsule called the theca, C-H-E-C-A. So you've got the theca, and then deep to that you will find granulosa cells with vesicles, and those will be covered by a zona pellucida. So I guess it's theca, zona pellucida, granulosa cells with vesicles, and then inside of there, your primary oocytes. Now, gradually, the secondary follicle will get larger and larger, and eventually it will become a visible bump on the surface of the ovary, which we call the mature follicle, also known as the Graafian follicle, capital G-R-A-A-F-I-A-N. Again, it's a visible lump on the ovarian surface. It can actually be seen by the naked eye. It's tiny, but it's there. It is within the mature follicle that the primary oocyte will divide to form a secondary oocyte, and then that's where meiosis 2 is going to happen. It's going to divide and form two things, actually. Whenever that primary oocyte divides, it doesn't split into two oocytes. It splits into one secondary oocyte, the cell that we call the egg, and one inactive cell called a polar body, P-O-L-A-R. Both of these have 23 chromosomes each, but the polar body typically will not go on to become an egg. It will typically degenerate. So normally, even though you technically produce two haploid cells from each primary oocyte, that does not mean you get two eggs out of it. Normally, you get one egg, one secondary oocyte, and one polar body, which degenerates and then dies. Now, let me just kind of summarize. There was a lot going on there. So our first step, even starting before birth, you're forming your oogonia, which have 92 chromosomes each. They are tetraploid cells, 4 copies of each chromosome. By the time the female is born, the cells will have been reduced. You will have undergone meiosis 1, and you will have a much smaller number of primary oocytes, which are diploid, have 46 chromosomes. Those are going to eventually give rise to our secondary oocyte, but not yet. The primary oocyte is going to be initially surrounded by a primordial follicle consisting of a layer of granulosa cells. As the primary oocyte enlarges, it will become the primary follicle, forming multiple layers of granulosa cells. Then it will become a secondary follicle when it is surrounded by the clear zona pellucida, and vesicles begin to form around within the granulosa cells. And the whole thing gets surrounded by a connective tissue capsule, the theca. Then that secondary follicle will gradually enlarge, becoming the mature follicle, the visible bump on the surface of the ovary. It's still a primary oocyte inside of there. It's still, at this point, just a diploid cell that has not formed true eggs yet. It went under meiosis 1 back when it first formed. It's not going to undergo meiosis 2 until right before ovulation. Basically, it's going to wait until just before ovulation. At that time, meiosis 2 will be completed, and the primary oocyte will split into a secondary oocyte, which we think of as the mature egg, and a polar body, which under normal circumstances degenerates and does not become a mature cell. Now, this brings us up to ovulation, O-V-U-L-A-T-I-O-N, which is the release of the egg. Remember, the male is the fast sex. The male forms lots of sperm very, very quickly. They're small, stripped down, tiny little cells. Basically, all they have is what they need to get to the egg and deliver their chromosomes. Males produce sperm continuously and rapidly, producing hundreds of millions of them a day, billions of them per week. Females are the slow sex. They produce eggs much more slowly. They release them much more slowly. And they make them much larger and more complex cells. They have to be larger and more complex cells for the very simple reason that they need to be able to continue development after being fertilized into a zygote and subsequently into an infant. So it's necessary that the secondary oocyte be a much bigger and more complex cell than the sperm. And if you look at a video of this, you can go online, find videos of sperm fertilizing eggs, and you'll see how much tinier the sperm are than the egg. That one egg will be surrounded by a whole cloud of sperm all trying to get into it at once. The sperm is a very teensy, stripped down little cell. The egg is a very large cell. In fact, the secondary oocyte is the single largest cell produced by the human body. It's not the longest cell. There are individual muscle fibers and nerve fibers that are longer, but it is the largest, widest cell produced by the human body. Now, the release of the secondary oocyte is known as ovulation, O-V-U-L-A-T-I-O-N. Ovulation is going to be what happens whenever the female is fertile and ready to potentially accept sperm. What will happen here is the mature follicle will rupture. The secondary oocyte, which is formed right before this, will be released into the peritoneal cavity. If all goes well, it will be captured by the fimbriae at the mouth of the uterine tube and swept into the ampulla of the uterine tube. Again, if the egg drops down, if the fimbriae don't catch it, it'll just fall down into the abdominal cavity, and at that point, you got nothing you can do. Now, after that happens, once ovulation has occurred, the egg enters the uterine tube. It will await fertilization there. That's where fertilization is going to take place. In the meantime, what is left of that ruptured follicle on the surface of the ovary is going to become a body called the corpus luteum. C-O-R-P-U-S, luteum, L-U-T-E-U-M. If the woman becomes pregnant, the corpus luteum will enlarge and become a body known as the corpus luteum of pregnancy. If the corpus luteum of pregnancy forms, it will remain visible on the surface of the ovary for months or even years after. Years after a pregnancy has occurred, corpus luteum of pregnancy will be visible there on the surface. If pregnancy does not happen, the corpus luteum will instead degenerate within about 10 to 12 days and become a much flatter little mark on the surface of the ovary called the corpus albicans, A-L-B-I-C-A-N-S. Corpus albicans will also remain visible for months or years to come. So we can actually look at the surface of an ovary, and we can get an idea if that woman has been pregnant within the last few years and how many times. Speaking of, one last really important thing about this, considering how ovulation normally works in our species, the standard ovulatory cycle in a human female is to release one oocyte at a time. Normally, there is only one egg available for fertilization at once. That is the standard in our species. Single egg fertilized, available to be fertilized at one time. The average litter size, if you will, for humans as a mammal is 1. We normally produce a single offspring at once. By the way, if you want to know the average litter size for any mammal, the way to determine that, count the nipples and divide by 2. You will find that most mammals have twice as many nipples as they have offspring in a standard litter size. And I think you can see why that is, because that's spare capacity. In the event of multiple births, in the event of twinning or something, having extra nipples beyond what you need means you can feed more than one young at a time. Obviously, in a lot of animals, the exact litter size is variable within a certain range. Cats and dogs, for example, you'll get anywhere between like 4 and 10 kittens at a time, depending on your cat, But normally, you will be able to count up nipples, divide by 2, and that will tell you what the normal litter size for a member of your species, the average litter size would be. For humans, 2 nipples, 1 infant at a time. Now, that does not mean, by the way, if you are one of the people who has the condition of polythelia, P-O-L-Y-T-H-E-L-I-A, which is the condition of having extra nipples, that does not mean you're going to have extra offspring. This is a species pattern as a whole. And now the reason for this, of course, is because normally only one ovary is active at a time. Only one of the 2 ovaries will release an egg in any given ovulatory cycle. That is the norm for our species. Sometimes there's a hiccup in the process. Once in a while, both ovaries will release an egg at the same time. Once in a while, a single ovary will release more than one secondary oocyte at once. Once in a great while, the polar body will become a mature secondary oocyte rather than degenerating, and you'll end up with 2. In any of these instances, you've got multiple eggs circulating around. Therefore, it is possible for more than one egg to be fertilized simultaneously, in which case you can end up with fraternal twins, F-A-R-T-E-R-N-A-L, fraternal twins, or dizygotic, D-I-Z-Y-G-O-T-I-C, dizygotic, 2 zygotes. That is, you fertilize 2 separate eggs with 2 separate sperm, and you end up conceiving 2 kids at once. Or in the case of triplets or quadruplets or any higher multiples than that, multiple eggs being fertilized by multiple separate sperm. Your fraternal twins are no different no more alike than any other pair of siblings from the same set of parents. Basically, they are just siblings who happened to be conceived at the same moments. That we call them non-identical twins because, again, it's two separate eggs, two separate sperm. They have no more DNA in common than any other set of siblings from the same parents would. On average, they share about 50% of their variable DNA. Now, that means that they can be one male, one female, or two males or two females. You can get either one depending on which particular sperm got to those particular eggs. That is your non-identical or fraternal twinning. Your identical twinning or maternal twinning, monozygotic twins, M-O-N-O, that happens post-fertilization. Monozygotic, one zygote, one egg fuses with one sperm. Subsequently, when the zygote begins its process of dividing, which we'll talk more about next time, and turning into an embryo and then eventually into a fetus, early in its developments, before it has distinct features, when it's still an embryonic body, the ball of cells that gives rise to a child splits in two. Because it came from the same fertilization events, same one egg fusing with one sperm, all the DNA came from the same original zygote. Ergo, those kinds of twins are what we call identical twins. They are going to have 100% of the same DNA. At a genetic level, they are clones of one another. And they'll both be male or both female, depending on which sperm originally created them. Now, they won't always stay identical throughout their lives. Life circumstances affect phenotype depending on their specific diet, environment, and other factors. You will find most identical twins begin to look a little bit less alike over time. That's not at all unusual, particularly if they live in very different environments. There's one other kind of option you may not know. The third option that we only discovered a few years ago is the semi-identical twin, also called sesquizygotic. S-E-Q-U-I-Z-Y-O-T-I-C, sesquizygotic twins. Sesquizygotic twins are interesting because what happens there is that one egg is fertilized by two separate sperm. Now, we're going to talk more about fertilization next time, but short version basically is once a sperm fuses with an egg and shares its DNA, that egg now has 46 chromosomes. Sperm had 23. Secondary oocyte is a gamete. It has only 23 chromosomes. Remember, primary oocyte had 46, splits in two. Each of those bodies has 23. 23 from egg, 23 from sperm, 46, standard human karyotype. Well, here's the thing. In order to prevent lots and lots of excess chromosomes, the moment an egg is fertilized, it immediately begins secreting compounds that kill other sperm that are nearby in an effort to ensure that it does not get multiply fertilized. But we have discovered that once in a great while, you will have a situation in which two sperm penetrate the egg at the exact same time, that two sperm deliver their chromosomal load at once. Now what that means is we have one set of maternal chromosomes, but two sets of paternal chromosomes. What happens in this instance is a thing we didn't know was possible until we discovered this about 10 years ago. And what we realized is that when that happens, if two sperm penetrate the egg at the exact same time, the egg will undergo mitosis. It's the only time we know of in which human gametes will undergo mitosis. Normally they don't do that. They are non-mitotic cells. They are produced to do one thing, and that is to fertilize or be fertilized. But if an egg gets two sperm, it will undergo mitosis, and each of the new eggs will get one of the two sperm. Therefore, we will end up conceiving two children at once, two zygotes, and those two children are going to then have identical DNA that came from mom. Their maternal DNA will be exactly the same because when the egg underwent mitosis, it made a perfect copy of its DNA, just like mitosis normally does. But they will have slightly different DNA from dad because two different sperm were involved in their conception. And as a result, that would be a situation where the kids are more alike than normal siblings would be, but they are not as alike as maternal twins would be. On average, your sesquizygotic twins share approximately 75% of their unique DNA, 75% of the variable DNA that differs from one person to another on average, they will have in common. Because they came from two different sperm, it is possible for them to be the same sex or two different sexes, depending on whether the sperm had X or Y chromosomes. We don't know how common sesquizygotic twinning is. It is believed to be a fairly rare event, but some obstetricians wonder if it actually might be the most common kind of twin, because the tendency to have maternal or fraternal twins seems to run in families, whereas sesquizygotic twins just require you to have two sperm that happen to get there at the same moment. It doesn't require a genetic predisposition, and therefore seems like it could happen to anybody. I should also point out that fraternal twinning, the release of multiple eggs at a time, is also sometimes a consequence of fertility drugs, that whenever a woman is on fertility drugs to stimulate ovulation, it is not terribly unusual for her to end up releasing more eggs at once than would be normal, and therefore triplets, quadruplets, multiples beyond that. Identical triplets are very rare. There have been like 5 cases. There was one born in Pittsburgh a few years ago. The mom was a student of mine. Like 5 cases in the past century thereabouts of like identical triplets. Identical quadruplets, there are like 5 recorded cases in all of medical history. Identical quintuplets, exactly 2 recorded cases. No multiples beyond that are known to be identical. All right, so I think I talked about it longer than I planned on here. We are done with oocyte development. We are done with ovulation. We are not done with the female reproductive system. So the next time we get together for this, we are going to talk about what happens during fertilization. We are going to talk about the female sex act. We are going to talk about female hormones and developments. We are also going to go into the menstrual cycle, menopause, and what happens when you feed the baby after it emerges. We're going to talk about the mammary glands and milk production. And at the end, if time allows, we'll talk about some select pathologies of the reproductive tract, a couple of reproductive cancers and a few other things that can go on during pregnancy, like endometriosis or prior to pregnancy, endometriosis or preeclampsia, a couple of other pathologies like that. Okay, I will leave you with a story. We like stories, don't we? I've already given you one about Gabriel Falloppio today, but let me tell you a personal story from my own life. And if you had me before for Bio 1, you might have heard this story before, so bear with me. So one day, years and years ago, I was in line at an event. I think I was at a Renaissance festival or something, waiting in line for food, and there were these 2 women standing in front of me, and they were talking about their kids. Now, I wasn't really listening to their conversation, I'm doing my own thing, but then I overheard something that made me pay attention. And one of the women, she said to the other one, she's like, well, you know my 2 boys, and she said their names. I don't remember their names. And she said, the doctor said they were twins. And I can see why he thought that, because they were born at the same time. But I don't think they're twins. And my ear perks up at this moment. I'm like, wait, what? What are you thinking? And the other woman says, oh, what do you mean? And the first woman says, now my one boy, he's definitely a twin, but the other one doesn't look anything like him. I have since come to greatly regret not butting into this conversation and asking what the hell she thought the word twin meant, whereby one of her children could be a twin, but the other one isn't because he doesn't look anything like the first one. And this is one of those things that has preyed on my brain ever since that rather baffling moment, and now it can prey on your brain too. Okay, so that is my lesson for today. Next one, we'll finish up the female reproductive system and some reproductive pathologies for both male and female, and that should tie this off. All right, hope you're all having a great day. Talk to you soon. Have a good evening.